Okay, our second speaker today is Dr. Tamar Taddei, and she's going to be describing multidisciplinary management of hepatocellular carcinoma.
Get out of here.
Well, thank you very much for the opportunity to speak. I'm going to give you a whirlwind tour of HCC today. And so my disclosure is really non-relevant to this talk. I'm doing some outcomes pharma-sponsored work at the VA. I guess my biggest disclosure is that I'm a hepatologist, so you are going to hear about HCC from a decidedly different perspective. So the objectives are for you to gain an understanding of indications for screening and surveillance, to learn about multidisciplinary approach to the patient with liver cancer, and to discuss therapeutic advances in the field. So HCC is really becoming quite an epidemic, especially now in the West. It's rising in incidence globally, but it's tripled in the US in the last 2 decades. It's the third most common cause of cancer-related death worldwide, claiming over 700,000 deaths per year, and it's the leading cause of death in cirrhosis. Now, when you look at incidence and mortality of HCC versus other cancers, and this is SEER data, you can see that over time, HCC has really become quite the winner in terms of both incidence, being second to thyroid, and then certainly lethality. So although thyroid is at much higher incidence than HCC, HCC is really a very lethal cancer. So here you can see the incidence in these sort of mauve bars against the survival in blue. And if at first glance it looks like we're making gains, right? Survival looks like it's going up. But survival is still really 12% at 5 years, which is abysmal. So while perhaps we're making some gains, I think that we really need to move quicker, especially in terms of rising incidence. So the risk factors for HCC are many. I would say that in terms of, if you look at global epidemiology, hepatitis B is the most important risk. It carries a 5 to 100-fold increased risk of developing HCC. And it really depends on whether you're a carrier, whether you have chronic HBV without cirrhosis, or whether you have chronic HBV with cirrhosis. So those patients with chronic HBV and cirrhosis are an exceedingly high-risk population. Now, HCV infection, which is much more pertinent to the Western population, specifically to the US, carries a 15 to 20-fold increased risk of developing HCC. And this obviously relates to advanced fibrosis. So these patients usually have cirrhosis, and that's what carries the increased risk. Understanding that hepatitis C has a 25 to 30-year latency to develop cirrhosis. The annual rate of developing HCC once you have cirrhosis is somewhere from 1 to 7%. Now, alcoholic cirrhosis is really second to hepatitis C in terms of the underlying risk for developing HCC. So while hepatitis C is the #1 indication for getting a liver transplant in the United States, there are many more alcoholics than there are patients who have hepatitis C. It's just that they don't get to transplant because they can't change their ways. We really don't know what the risk is, but we do know that the more established cirrhosis is, the more likely you are to develop HCC. There's no clear etiology for somewhere between 30 to 40% of cases diagnosed in the West, and we think that we're seeing rising incidence in patients with non-alcoholic fatty liver disease, specifically those with the so-called metabolic syndrome. Now, we know that there's a 2-fold increase in patients with obesity and a 2-fold increased risk in patients with diabetes, but both of these populations have increased risk of cancer overall. So teasing HCC out of that is difficult. So I think it was 2012, the CDC basically set forth a directive to do one-time hepatitis C testing in all baby boomers. So anybody born between 1945 and 1965, the advice from the CDC is to go ahead and do one-time testing for hepatitis C. About 75% of patients currently infected with hepatitis C in the US are actually born in this birth cohort range. And it's anticipated by offering one-time testing, we'll probably get another 1 million cases of hepatitis C infection, okay? So the ICD-9 people gave a V code for it, and there's very clear directives from the CDC. The problem is that a lot of these patients will be diagnosed with a triple whammy. They'll be diagnosed with hepatitis C, with cirrhosis, and with HCC. And unfortunately, that's what we're seeing a lot of since this directive came through. This has also been endorsed by the United States Preventive Health Services Task Force, so more and more primary care docs are now testing for hepatitis C. So this data comes long before the new direct-acting antiviral agents for hepatitis C, but it showed a projected prevalence of what we'd be dealing with in the coming decades. So you can see that HCV infection, about 3.2 million Americans are infected. These numbers are a little bit underestimating that. And then as far as that, a much smaller percentage have cirrhosis, although we are seeing more and more cirrhosis as the birth cohort is aging. So people who contracted their hepatitis C in the 60s and 70s have the latency now to actually have cirrhosis, end-stage liver disease, and HCC. And of course, HCC is not expected to peak until somewhere around 2020 to 2030, and then liver-related death is only going up. So many of you have seen, even just in perhaps the 3 years you've been here for residence here, for fellowship, or however many years you've been on staff, that our liver patients are kind of adding up in the MICU. We're having more and more liver patients. Now we have a liver center, and obviously we have a transplant center, so that obviously brings referrals, but liver disease is becoming more and more prevalent in the hospital because of these aging cirrhotics developing complications. Of course, the one of which that I'm concerned with is HCC. So who do we screen and how do we screen? So the guidelines that hepatologists follow are from the American Association for the Study of Liver Diseases. There's many other societies. There's a European Society, an Asia Pacific Society, and all of these bodies basically endorse screening with an ultrasound every 6 months. So all comers, anybody with cirrhosis, should get an ultrasound every 6 months. If you detect a lesion by ultrasound, then you move to, dynamic contrast-enhanced imaging. And the reason that HCC can be diagnosed by imaging alone, which of course is anathema to oncologists, it's very tough to say you have a cancer without having a piece of tissue. But the reason that we're able to do this in HCC is because these tumors enhance in the arterial phase and wash out in the portal venous phase. As you remember from anatomy, the liver has a dual blood supply, which is what makes it such a cool organ. It's fed by the hepatic artery, and it's also fed by the portal vein. So the portal vein delivers all the dirty intestinal blood to the liver to filter, and the hepatic artery gives it rich oxygenated blood. But these tumors are fed preferentially by the hepatic artery, which makes them very bright. And then in the portal venous phase, they become like black holes. It's absolutely characteristic for HCC. The only other tumor that can do this in the liver is a metastasis from a renal cell carcinoma. So if a person has another primary malignancy, then obviously you want to think about what you're looking at. But in the cirrhotic with imaging like this, it's HCC. So the other group that we screen are non-cirrhotic hepatitis B carriers. These patients, as you know, are at risk. And here you have the world prevalence of hepatitis B in blue juxtaposed against the annual incidence of primary HCC in red. And Asian males over 40 should be screened, Asian females over 50, Africans over 20, and anybody with a family history of HCC should be screened 10 years prior to their first-degree relative, prior to the date of diagnosis, or age of diagnosis, I should say. So these recommendations come from those hepatology governing bodies, and what's really interesting to note is that the lifetime risk of developing HCC in a person with chronic hepatitis B is somewhere between 10 to 25%. And it's 25% in many of the folks who vertically acquired their hepatitis B at birth, okay? So based on the 370 million people across the world who are infected with hepatitis B, somewhere between 35 to 87 million are projected to die from HCC. And this is a vaccine preventable illness. So what we see in the West is a tip of the iceberg compared to what the rest of the world is seeing. Now, many of you may look at that Africans over 20 and say, that's really weird. I mean, are people really dying of liver cancer, in their 20s? And the answer is yes. And the reason is that folks in Africa have endemic hepatitis B, so many of them acquire the virus at birth, and then they're exposed to aflatoxin from birth because they're unable to store their grains under 50 degrees Fahrenheit. Aflatoxin is ubiquitous, it's a carcinogen, it synergizes with the virus, and many people in Africa are dying in their 20s and 30s of HCC. Again, we just see the tip of the iceberg here. So is screening controversial? And the answer is yes. So the United States Preventive Health Services Task Force has not endorsed screening. The Institute of Medicine has not endorsed screening. And the American Society of Clinical Oncology have not endorsed screening. Why? Because the evidence is simply not good enough. The one oncologic society that has endorsed screening is the National Cancer Clearinghouse Network. And you can see there's been sort of a very vitriolic debate in the press about this, which was spurred on by this particular op-ed piece in the Annals of Internal Medicine, which basically said that the reason we screen is based on a study in China, which looked at about 18,000 patients. It's this particular study right here, published in 2004, which showed a clear benefit of survival in those who received ultrasound as opposed to those who did not. But it was in a lesser-known journal. There were issues with the statistics, and the other issue is that, you know, when you're comparing many Asians without cirrhosis but with hepatitis B to a Western population, can you really endorse ultrasound in a totally different population, especially a more obese population? So is ultrasound the same in Asia as it is in the U.S.? So this has actually brought about many other papers and editorials, and actually it was tried in Australia to have a registry trial where basically the patient could decide whether they wanted to be screened or not, and not a single patient signed up for the non-screening arm. So now it becomes an ethical question. Can we really do this? And I think the answer is probably not. We should probably look at things like screening intervals and screening modalities and tease the data out of those kinds of studies, as opposed to just continually fighting each other in the literature. One of the studies that came out that tried to answer this question was a meta-analysis, which was looking at multiple different papers, ultimately 12,000 patients involved in all of these papers across the globe. And this study did see benefits to screening for both survival, early stage disease, for curative treatment. In the VA, and I spend half of my time at the VA, there was a systematic review that was commissioned, and they also saw no evidence to screening. So this is something that's up for public comment and debate. So this is a very interesting area in HCC that the debate rages on. So once we have this abnormal image, your ultrasound that's abnormal, then you go to one dynamic contrast enhanced image. It could be an MR, it could be a CT. You certainly need the proper phases, so you need arterial phase, a portal venous phase, and a delayed phase. And if the imaging is atypical, then you really should consider biopsy, specifically if the patient is not cirrhotic. A negative biopsy doesn't rule out malignancy. The liver is a big organ. If you're going for a very small lesion, you could graze, the side of it. You could get some crush artifact, but not the malignancy itself. So if that lesion continues to grow, then you would obviously bring the patient back for rebiopsy. In nodules less than 1 centimeter, we should follow them with every 3-month imaging. Usually an ultrasound would suffice, and once you see growth on ultrasound, then you bring them back for dynamic imaging. You can imagine that we probably are doing a whole lot of imaging, and we are, because it's very often that you'll find a 1 centimeter lesion. Even in a healthy person, it could be a cyst, it could be nothing. This is why we limit the screening to cirrhotics. If we started screening everybody with hepatitis C or hepatitis B, we would probably be screening far too many patients. So the AASLD guidelines are recapitulated here, and it's basically what was in the previous slide, but really we're only focusing on things over 1 centimeter, and nowadays radiologists tend to call everything, a 5 millimeter this, a 4 millimeter that, a 7 millimeter this. Forget it, okay? If it's over a centimeter, you can worry. If it's under a centimeter, you can just get an ultrasound in 3 months and see what it is in a cirrhotic. Again, it's the only solid organ malignancy for which radiographic diagnosis is acceptable. Again, that's anathema to oncologists, and I think it's not very good for posterity, because without understanding the molecular basis of this disease, we can't really move forward. But you can certainly say it's an HCC. So the staging classifications for liver cancer are many. There are 7 staging classifications in use around the world, which is a little dizzying. This is the one that most hepatologists use. So in tumor board here at Yale, we use the AJCC 7 staging classification, but then we also use the BCLC. And this comes from Barcelona, and you basically start with your HCC, and then you actually think about the patient's liver disease. So this cancer arises in 80% of the time a very sick organ. So you have to decide how sick is this patient before you even look at their tumor burden. Once you've decided whether they're a child A, B, or C, you can then decide on their performance status. So, do they have a whole slew of other comorbidities that might preclude any therapy? So obviously you have to think about the patient before you think about their tumor burden, especially in liver cancer, and then you assess their tumor burden. Now, when you talk about liver cancer, there are certain things that are very important. It's also the only solid organ malignancy for which transplant offers a durable cure, okay? So there are patients who really should be shunted towards either resection or transplantation. Patients who have intact liver reserve should go for resection. Patients who do not should be considered for transplantation. Transplantation is reserved for patients with controlled disease, which is within Milan criteria, which is 1 tumor no greater than 5 centimeters or 3 tumors none greater than 3 centimeters. And we're trying to push the envelope with this to see if we can actually downsize people, and certain biology is better than other biology. So HCC in and of itself is a very heterogeneous cancer. This algorithm offers, not only different treatments according to stage of disease, but then it sort of gives a gestalt of how many people really should be eligible for curative treatment versus randomized controlled trials versus, symptomatic treatment. And this is constantly being revised by the authors and has actually served its purpose and has been validated in many other studies. As far as the AJCC 7 staging, it's your usual TNM staging, but it really doesn't tell you anything about the patient's liver disease. It doesn't give you any clue, does this person have decompensated cirrhosis? Have they had ascites, variceal bleeding, jaundice, encephalopathy? So this doesn't really give you a very clear picture on what the patient could tolerate in terms of treatment. And this is actually newly revised to separate out stage T3 into A and B, understanding that any kind of portal vein or hepatic vein invasion is really a significant game changer in HCC. So the factors that determine prognosis are the usual, so tumor stage, size, number, location. The game changers are vascular invasion, as I said, and extrahepatic spread. So once you have vascular invasion or extrahepatic spread, you can't be considered for resection, you can't be considered for transplantation. Liver function is key in terms of deciding what therapy a patient can tolerate, as is overall patient health. We do use ECOG performance status. In the transplant world, we use a Karnofsky score. They're similar. And obviously, whatever you decide on in terms of therapy should match what that intervention is supposed to do. Is it palliative? Is it curative? Et cetera. So we discuss all of our patients in tumor board, and our tumor board's a little bit different. It's run by a hepatologist, which is very different. And surgery, we actually have 2 surgical disciplines there. We have transplant surgery as well as surgical oncology, very different perspectives. And we kind of swap out radiation oncology for interventional radiology, although it's quite possible that radiation oncology will have a seat at the table as trials are going on to learn about the role of SBRT and HCC. So as far as how we treat these patients, many of these treatments are actually done long before the patient ever walks into the oncologist's office, which may or may not be a good thing. I think really the important thing is that everybody should bring the case to tumor board because there's a dizzying array of therapies. So the curative treatments are resection, ablation, and transplantation. Resection is obviously removing the mass. This is the choice of therapy in non-cirrhotics, which is why all of the really great resection data comes out of Asia, where many hepatitis B patients have resection of very large tumors and do very well. In cirrhotics, this is really reserved for the child's A patient who has never decompensated, and we always avoid a full right hepatectomy because they can't regenerate as well. It's best for solitary HCC, and in the West, less than 15% are eligible for this type of therapy at the time of diagnosis. Survival, as you can see, is excellent for 1 and 3 years. 5 years, it drops off considerably because of the recurrence risk, which is a 70% recurrence risk at 5 years in patients with cirrhosis. Why? Because that cirrhotic milieu is still there, and that's the fertile ground for HCC. Ablation is effective when the tumors are less than 3 centimeters. There's multiple modalities. You name it, they think of it. Thermal, chemical, they can do whatever to burn or kill a tumor. It's minimally invasive. The survival is very similar to surgery, so the onus is on us to really select the patients properly. And again, the recurrence rate is the same. Transplant's the panacea, right? It cures both. It takes out the cirrhotic liver, gives you a brand new liver, brand new lease on life. There are exception points for transplant if you fall within the criteria I mentioned, but the demand far outweighs the supply. And the survival is excellent. The 5-year recurrence rate is 15% in those who are properly selected within the Milan criteria. Unfortunately, I think as long as the demand outstrips the supply, we really need to find better ways of dealing with these cancers. And I think that a person with a really well-functioning liver and a small cancer really may not need a transplant, especially now that we can cure 90% of patients with hepatitis C. So there have been recent studies looking at the cost effectiveness of resection versus orthotopic liver transplant, and papers have actually shown that orthotopic liver transplant is less cost effective than resection at certain tumor burdens, and certainly in a patient with child's A cirrhosis, resection should really be considered. This was done over 3 different cost scenarios: US, Switzerland, and Singapore. Palliative treatments, we have TACE and Y90. TACE is transarterial chemoembolization. This is reserved for non-surgical patients with large or multifocal HCC. We often will use TACE and ablative techniques adjunctively in patients with lesions that are between 3 and 5 centimeters. The survival here is about 40% at 2 years. The newest kid on the block is yttrium-90 therapy, which, as you know, is used for neuroendocrine tumors. It's offered for non-surgical patients with multifocal HCC and vascular invasion. Why? Because it doesn't deliver an ischemic insult, unlike chemoembolization, which does. So when you do chemoembolization, you insert these doxorubicin-loaded beads through the hepatic artery into the tumor, and then you close off the blood supply. With Y90, you give them their Y90-loaded beads, but you leave the artery open. So it's a little bit better tolerated, and certainly better tolerated in people with vascular invasion. So where we really desperately need help is with molecular therapies. So you know that there are developmental and oncogenic pathways that intersect to promote cell proliferation, stemness, and immortality. And some of these canonical pathways have been identified in other cancers. We're still kind of looking for some canonical pathway in HCC. So oncogenic addiction loops are a tumor cell's dependence upon a molecular alteration for its proliferation, like BRAF mutations in lung cancer, for example. We don't have a single loop in HCC, so we rely on a dirty tyrosine kinase inhibitor called sorafenib, which was approved for renal cell carcinoma. As I mentioned, both of them very vascular tumors. And it has a tolerable side effect profile when dosed artistically. But the issue is that sorafenib came on the market in 2008. It's now 2014, and we don't have any other agents for HCC, and that's really unfortunate. So there's a lot of work being done on the genetics and molecular pathways in HCC, and honestly, this is what is important to develop new therapies, and this is why I think it's a detriment that we make this diagnosis radiographically so often. We have now been able to see that the morphology of HCC is very different, and we might be looking at distinct tumors and calling them all HCC. So fibrolamellar HCC, for example, a different disease, happens in young women, usually has a more indolent course, although it's also very lethal. These seem to have more neuroendocrine profiles, and they also have a lot of perhaps stemness, meaning they have more of a stem cell profile. And more recently, they actually found a particular deletion that was present in 100% of fibrolamellar HCCs. The other very interesting paper came out last year, actually, oncofetal gene SALL4 in aggressive HCC. So this is an oncofetal protein that really should not be expressed in the adult liver, but they have actually found this in HCC, especially in aggressive HCC, so this may be a therapeutic target. And then methylation analysis and epigenetic unmasking, this group looked at particular tumor suppressor genes in HCC, and what's interesting is that many of these genes are active in autosomal recessive liver diseases. So it may really point to certain cascades that we already have some understanding of. And then obviously many people are using gene scores to determine prognosis, and there's a good body of literature in HCC. The problem is that unless you make everybody get a biopsy, you really can't apply these techniques. So I think at some point, we have to say, your liver tissue may actually help you down the road. So chemoprevention, many people say, well, what are you doing for chemoprevention? There was a beautiful review looking at statins, thiazolidinediones, metformin. Certainly when it comes to the obesity and NAFLD population, we think there's quite a bit we can learn from chemoprevention. And generally this sort of algorithm came up, which basically the authors say, you should certainly treat any viral hepatitis, and then if they have metabolic syndrome, consider statins as clinically indicated, use metformin or thiazolidinediones in your diabetics, consider aspirin if the patient doesn't have portal hypertension, drink as much coffee as you can because it's antifibrotic. And vitamin E is also helpful in people with NAFLD, but not at super high doses, usually around 400 IUs per day. Certainly we know the story from the East shows that chemoprevention really helps. So people who were treated with entecavir over time to suppress their hepatitis B viral load, these folks actually were much less likely to develop HCC. In HCV, we're now seeing new data that suggests that obtaining an SVR, or sustained virologic response after treatment, also helps prevent HCC in all stages of fibrosis and in those with advanced liver disease. So in summary, the incidence of HCC is rising. It's a complex and heterogeneous cancer, clinically, morphologically, and molecularly. Many treatments are available, and some of those treatments seem really strange to the oncologists, like wait until the tumor is 2 centimeters so that they can get the benefit of transplant. That's very hard to tell an oncologist, not let alone the patient. I have cancer and you want me to wait? Standard of care is a moving target. A multidisciplinary approach is absolutely necessary. And obviously, personalized therapy requires understanding molecular and genetic underpinnings so that we can predict behavior in response to treatment. Chemoprevention may have more relevance now with curative hepatitis C therapy, so I think the more folks we are able to cure, the less likely we'll see HCC. So I think our numbers will fall off, but it probably won't happen for another decade and a half. And then, of course, NAFLD will be the next big scare. So I'll take any questions.
Thank you, Dr.